So I'm Nathan Collins. As Dr. Freed said, I'm one of the R3s who will be moving on next year. The topic today that I've chosen to talk about is something that we've all had experience in managing over the past 3 years. It's alcohol withdrawal, and what the best medication or the options for medical management are in treating alcohol withdrawal. And there's been a lot of controversy and hesitation with use of barbiturates because of passed on throughout the years and the history that barbiturates include. So the title or the myth today that I will attempt to bust is barbiturates should not be used to treat alcohol withdrawal due to their high risk of respiratory failure. Barbiturates can be given orally, IV, just almost 100% bioavailability between oral and IV dosing. Some slang terminology that's been used are red birds, red dogs, and the list is there. Pharmacological action of barbiturates is that it acts on the GABA A receptor in the brain, and it actually directly binds to the GABA A receptor to open the chloride channel. It affects the duration of how long the chloride channel is open, which is thought to be the problem with barbiturates. In 1903 is when they were first invented. Two authors published a paper on a new hypnotic called Barbiturates. Emil Fischer was a Nobel Prize laureate. It was the first organic compound to be prepared synthetically from urea. The dispense was cocoa flavored, so probably didn't help with the addictive aspects of barbiturates. In 1919, phenobarbital came to be. The clinical uses for barbiturates are plentiful: epilepsy, anxiety, anesthesia, central tremors, migraines, schizophrenia. All have been used. Barbiturates have all been used to treat these conditions. Basically, they're used to depress the central nervous system. But unfortunately, barbiturates have had a bad rap, and most things that get a bad rap happen because of media. Barbiturates have claimed lives because of overdosing, suicide, and things like that, which led to respiratory failure. Marilyn Monroe was found dead in her room, and her death certificate actually showed that she died from acute barbiturate poisoning. And Judy Garland died from barbiturate overdose. And then these were in the 60s, and barbiturates kind of lost favor before, or at that time, and before this happened. In 1997, there was a mass suicide with a cult that thought they were going to get to another dimension. So they overdosed on phenobarbital and vodka. The picture in the middle actually shows the site that law enforcement came to see when they heard about the suicide. Deaths related to barbiturates increased significantly during the 30s to 60s. Over a 6 period of time, and from 1957 to 1963, 8,400 barbiturate overdoses were noted just in New York, and 1,100 deaths associated with barbiturate use. No matter what barbiturate that was used, none of them, based on the formulation, overcame the dependence and death by overdose that barbiturates would lead to. And in fact, it was thought that the two authors who brought barbiturates to be actually became dependent and died of overdose from the very drug that they invented. The number of suicides involving barbiturates was only second to carbon monoxide poisoning at one point, and New York hospitals were reporting that one death every 36 hours was related to a barbiturate misuse or abuse. So that led to a lot of campaigns to decrease prescriptions of barbiturates. The Advisory Council campaign in Britain campaigned on the use of and restrictions of barbiturates, the Medicines Act of 1968. These were all in relation to stopping the amount of barbiturates that were being prescribed. So then 1960 came along and Librium came to market, and this was thought to be the greatest drug in terms of being able to use in the same settings as barbiturates, and was thought to have less respiratory depression that would lead to rare lethal overdose. This is a ad that I found on a website that said that the higher dose of barbiturates can lead to death, but benzos alone can't lead to death based on their physiology. From my experience treating patients here, it's not necessarily true. In the literature review I've done, that's just not true. Why do they think this? Basically because benzodiazepines act on the GABA-A, the same receptor, but they act at a different site to sensitize the receptor and then change the frequency at which the chloride channel opens to hyperpolarize the cell and cause the inhibitory state. Do barbiturates always lead to respiratory failure and death? Well, in alcohol withdrawal, there have been multiple studies, not all great studies, but multiple studies that have tested the use of barbiturates in alcohol withdrawal. So here was a protocol that was used to treat alcohol withdrawal in 70 patients. They started with a loading dose of 15 mg per kg, followed by a maintenance dose, and typically after the loading dose, they would target a phenobarbital trough of about 20 micrograms per milliliter. That has not been shown to be toxic in terms of respiratory depression. With this protocol, there were no cases of respiratory depression, mechanical ventilation due to respiratory failure noted in these patients. There was another retrospective study done by Michelson and colleagues that evaluated phenobarbital use and diazepam. They just wanted to compare the complications and effects in the use of alcohol withdrawal and delirium tremens. So you notice the total mean dose of phenobarbital over 1 to 2 days was 1,500 milligrams to 2,200 milligrams. And their conclusion that alcohol or phenobarbital was just as efficient as diazepam in the treatment, and yet there were no significant findings in terms of respiratory complications, intensive care unit, cardiovascular complications. In January 2009, March 2010, Rosenson and colleagues did a randomized control trial with 10 milligrams per kg of phenobarbital plus a lorazepam symptom-guided treatment and compared it to a placebo in lorazepam. So basically loading a person with phenobarbital up front and then using lorazepam for symptom-guided treatment thereafter. And there were no differences in intubation between the two groups, with 10 milligrams per kg being used up front in the treatment arm. This was another retrospective study that was done that compared a pre-guideline to a post-guideline treatment regimen of phenobarbital and diazepam. Basically, the pre-guideline was lower doses of diazepam and no emphasis on use of phenobarbital. The post-guideline was increasing doses of diazepam and the addition of phenobarbital for uncontrolled alcohol withdrawal syndrome. I guess if some is good, more is better. So what did they find when you add higher doses of diazepam and phenobarbital, which you would think should just considerably increase the incidence of respiratory failure? Well, they found the exact opposite. Phenobarb, in addition to high doses of benzodiazepine, actually decrease the rate of mechanical ventilation. The thought is that they are able to control the agitation and sympathetic response of alcohol withdrawal early, so it led to better control later, and they avoided mechanical ventilation both for resistant agitation and respiratory failure. That is the evidence that shows alcohol withdrawal syndrome and the treatment with phenobarbital. So my conclusion from all of that data that I found was there's clear evidence that misuse or abuse of barbiturates in the outpatient setting can lead to overdose, respiratory failure, and death. But there is also evidence that shows that use of phenobarbital in monitored settings actually has no significant difference in the complication respiratory failure when compared to the alternative drug, which is benzodiazepines. These are my references.
All right. Any questions for Dr. Collins? I think a lot of the people here have been using phenobarbital for a while, for at least several years now. I don't use it a lot. I think Dr. Buxman kind of brought it back from way back.
Yes.
But I think this is a good example of how drugs themselves are not inherently bad necessarily. It's just the misuse of drugs, and like you said, it got a really bad rap from all of the overdoses. And I was just looking up to see how many overdoses, opiate overdoses there are in, I think, what was it? How many were of the overdoses were there in New York?
So
It was like 1,700 or 1,500 or something.
Yeah.
In like an 8-year period of time.
Yeah.
Well, there are 3,224 opiate-induced deaths in New York State in 2017, just in 1 year. So it was many, many-fold greater than what you're seeing here, even accounting for the change in population. Okay, yeah, Dr. Fitzgibbons, did you?
Dr. Hunter.
Oh, I'm sorry.
I just had a quick question about the dosing. So 15 milligrams per kilogram for 70 kilograms versus like 1,000, right? And normally we'll give like 260, that's like the most we'll give. So were they doing like 260 Q6 for a day, or do you know how the dosing worked?
No, so that protocol basically was initially they did 40% of that dose, so 400 milligrams up front, and then 3 hours later they would hit him with 300 milligrams, and then 3 hours later 300 milligrams. This protocol was a fixed amount to get to a serum concentration of phenobarbital. But studies have shown that symptom-based treatment, we use the Seawall protocol here for any symptoms based on the scoring system. That's been shown to decrease the amount of benzodiazepines. That's all they do studies in, is use of benzodiazepines, because phenobarbital's fallen out of favor. But symptom-based treatment has been shown to be better than fixed dosing like this is. But this is just an example of how high of phenobarbital doses we can use, and patients aren't going into respiratory failure.
I know it's not your myth, but what's the advantage of using phenobarbital?
So the long half-life of phenobarbital allows you to get control of symptoms up front, and then you don't have to keep redosing as much as you would with benzodiazepines. And in a lot of patients who come in with alcohol withdrawal, they tend to leave AMA. So they're not going to go out into the world and seize and aspirate or something. So I think it's a little bit safer.
But my question is actually related to Dr. Thrash's question. So, and it's not your myth, but I always wonder the outcome. So that's the risk. The risk is I don't want to buy it, but certainly the risk sounds like it's a myth. But the benefit, as far as outcome at 2 weeks, outcome at a month, because I think to your point, one of the things we're thinking is that the phenobarb is sticking around for, 90, 100 hours perhaps, right? And is it actually in the patient's best interest from the alcohol withdrawal perspective downstream? And actually, is there an abstinence? Is there any other kind of trickle-down benefit?
So the studies that have been done haven't had great 30-day follow-up because of the inherent disease that the likelihood that the patients who are treated with this would follow up. So I think it's difficult to get those numbers.
Do you think it's better? Do you think those patients will do better?
So yes, if they leave, it's safer because the amount of Librium we're using doesn't always control the symptoms up front, whereas we have better control with the phenobarb and the IV nature and the long half-life. So we can get control of the symptoms up front, and then if they leave, the long half-life should get them by. And typically, if someone's loaded with phenobarbital, in my experience, I haven't had severe withdrawal in the near future following with them leaving.
It's like an automatic taper.
Exactly. But this is not the only way to use, or not the only management. What's great about medicine is that we have multiple options. This is just another option that I don't want people to be nervous about applying because of what history has shown to be a consequence.
So it's been a while since I've done alcohol withdrawal. So what do you guys been doing on the wards? How do you do this kind of a load? And or how are you doing it on the ward?
So there are other studies on phenobarbital and alcohol withdrawal, and we'll typically load them with 260, and it's been kind of hard to treat appropriately, just because of the myth that's been perpetuated. And so what I would typically do is load them with 260, and then every hour that their seawall is greater than 9, I would give them 130, up to a total daily dose of probably 10 mg per kg. So they typically don't need more than a third dose of 130, but the frequency at which it would be given it causes a lot of anxiety with staff. So.
And then you're just following the C1 protocol.
Yeah.
For adequate.
That just period. You can use both. That's what one of the study here shows, is that you can use both the phenobarb up front and then Ativan thereafter, because the phenobarb will still be in their system. So that's and then you just keep them on continuous pulse oximetry to maintain. If anything does happen in terms of respiratory depression, you have that monitored.
All right.
Any other questions?
I'm trying to remember, maybe some of my other elderly colleagues will remember. What wasn't the loading dose for phenobarb like for seizure? We used to use it for seizures all the time. Wasn't it about 15 per kilo?
1,500 milligrams.
Yeah. So it's very close to that pretty large loading dose, and those people, they were having seizures. They were awake. They didn't have any respiratory problems.
Actually, Jeff,
So-
Steve and I used foraldehyde, and it was usually half a cup per rep.
I've been trying to find somebody that actually was old enough to abuse foraldehyde.
Oh, yeah.
Really?
We used it all the time at Crossing City Hospital. We would know
Okay.
there was somebody in DTs from the stairway going past the ward.
The smell.
This perfume, much nicer than some of these things that you plug into the wall.
Yeah. All right, so is it a myth? Barbiturates should not be used to treat alcohol withdrawal due to their high risk of causing respiratory failure. So how many people feel that this is a myth, or that this is actually a true statement? How many feel that it's... Pardon?
We're voting it's a myth or it's true.
Well, we're voting whether this statement is true. How many believe it's true, it should be confirmed? How many feel that it's plausible? And then how many feel that it's busted? That's pretty unanimous. Wow. It's been a while since we've had a unanimous vote here. So.